morning, everyone. Warm welcome to you all to yet another exciting webinar brought to you by Blue Connect. This particular webinar was sponsored by Falcon iLab. A big thank you to Falcon iLab. My name, as you might be knowing it, is Maimo Kobe. I am the administrator for the platform. Also to say a million thank you to all of you for taking time to come and attend this this webinar. And also a million thank you to our presenter, Miss Yurisa Naidoo, who will be giving us some contact lens today. Just a reminder, colleagues, that this is a webinar, so it depends largely on connectivity. So please do expect some delays in transmission. The voice might be ahead of the video or vice versa. I have noted that sometimes people do get disconnected. Please just reconnect. In some instances, you might need to log off and on because the problem might be on your side. If there is a problem with connectivity, I will be able to pick it up and I will then be able to say so. For those of you who are joining us for the first time, please note that the system does not allow us to collect your CPD HPCSA numbers, rather. So you are please requested to send your HPCSA registration number to the email that I will broadcast during the webinar. For those of you who have done so, there is no need to do that again. We already do have your HPCSA registration number, and we will be generating certificates. Some of you might have received your certificates already. Some of you will receive your certificates during the course of today and tomorrow. As I did say yesterday to those who were attending, we are using a bulk emailing system, so it might be a bit slower in sending your CPD certificates. If you do not receive your certificates by Thursday or Friday, please drop us an email. We will then send you your certificates directly. Without wasting any time, allow me to welcome Ms. Yurisa Naidoo, who's an optometrist at Devon, eThekwini. Ms. Naidoo, please, the time is now yours.
All right, thank you very much. Good morning, colleagues. My name is Yurisa Naidoo. I do a little bit of all sorts, but today my all sorts includes talking to you about specialty and therapeutic contact lens fitting. Okay, so by way of introduction, when we talk about specialty contact lens fitting, we're pretty much talking about everything that's out of the ordinary in relation to fitting a contact lens, whether it's a soft lens or a hard lens or cosmetic lens. So we correct complex refractive errors are considered as specialty fitting, very complex refractive errors. Corneal ectasias cause these kind of refractive errors, for example, keratoconus and pellucid marginal degeneration, etc. Aphakia in children, especially. Ortho-K is also considered a specialty fitting, and prosthetic contact lens fitting. But here I'm not talking about prosthetic eyes, I'm talking about prosthetic contact lenses. So these are fitted for cosmetic as well as functional purposes. Therapeutic contact lens fitting is actually a specialty process as well, but I've dealt with it a little bit more specifically so you can understand when the context in which we use therapeutic fitting principles. The reasons we'd fit lenses therapeutically is for pain relief, to promote epithelialization of the cornea, to protect the cornea, to promote hydration, and nowadays there's new technology in contact lenses, which we'll be going through a little bit later. New exciting stuff to help monitor things in the eyes. So basically the presentation will deal with a review of the anatomy of the cornea and the limbus, and then we'll go into the actual specialty contact lens fitting, dealing with hybrids, soft lens, specialty soft lenses. I'm not talking about your regular TORICS soft lenses. I'm just going to mention these. I'm not going to deal with them in detail. The same with RGPs, because you've probably learned this to death in your university days. I will focus a little bit more on scleral fitting, because scleral fitting is something that most of us didn't actually do as part of our curriculum in our undergrad years. Then we'll take a break and have a few questions and a bit of a discussion, and we can move on to the next section on therapeutic fitting. So it's important to understand the anatomy of the cornea, because the cornea is the surface that we're working with. And if you understand the anatomy and the physiology of it, then it makes fitting and monitoring and evaluating your contact lens much, much easier. So this is stuff we all already know, that the cornea contributes 70% of the refractive power of the eye, and it contributes approximately 44 diopters to the power of the eye. The diameter vertically is approximately 11 millimeters and horizontally approximately 11.8, give or take a few millimeters or a few microns. When the corneal diameter is 13 millimeters or larger, we refer to this as a megalocornea, and you can see a megalocornea in this little baby's eyes here. And when the cornea is less than 10 millimeters or less, you can see that compared to a normal sized cornea, then we refer to that as a microcornea. Okay, so now talking about the radius of curvature of the cornea, we know that the average central radius of curvature is about 7.8 millimeters on the anterior surface and about 6.5 millimeters on the posterior surface. The normal corneal curvature ranges from 7 to about 8.5 millimeters. The central 3 to 4 millimeters is what we call the corneal cap, and this is nearly spherical, the surface. Thickness of the cornea is approximately 523 microns, give or take about 39 microns. And in the periphery, the thickness of the cornea is about 660 microns, give or take 76. So this is an OCT image from an OptiView. The reason I put this up is simply to illustrate in different zones of the cornea from this instrument what the corneal thickness is, approximates. So now going into the layers of the cornea, you know these already. Epithelium is the first one, that is the most anterior surface, then followed by Bowman's membrane, the stroma, Dua's layer, Descemet's membrane, and the corneal endothelium. And if we take a slightly closer look at the epithelium consists of 3 types of cells, and the anterior most of these cells are the surface cells, which you can see here. Right? There's about 3 layers or so of surface cells. They're flattened cells, and they have these microvilli here. These microvilli help to keep the tear film in contact with the cornea. That's followed by the wing cells, and again there's about 2 or 3 layers of wing cells that move around here, and these are the ones that slide up and do all the healing on the cornea quite quickly and easily. And then the bottommost layer is the basal cells, and the basal cells are a single layer of columnar cells that are found adjacent to the basal layer. So there's the basal layer here, which has these hemidesmosomes in them, and that form tight junctions. Below the epithelium is Bowman's membrane. So an important thing to note about the epithelium is that it has regenerative properties. So if it gets damaged, it regenerates, right? Bowman's membrane, on the other hand, is a bit different. When it scars, when it gets damaged, it doesn't regenerate. So then it forms a scar. It's an anterior condensation of the stroma. It binds the stroma to the epithelium, and it is a very strong barrier to injury, pressure, and infection. Now, moving on to the stroma. The stroma is about 500 microns thick and occupies 90% of the corneal thickness. It's composed of collagen fibrils, keratocytes, and extracellular ground substances. The lamellae, or these layers here, right, these lamellar cells in the cornea are arranged in parallel, and there are about 200 to 250 layers of lamellae in the stroma. Going back to the stroma, you may ask about corneal cross-linking that many of you may have heard about. The cross-links are made from collagen fibrils, and these hold the lamellae more or less in place, connect them to each other rather. The newest layer, called Dua's layer, is a thin layer that is it's defined layer. I don't want to say it's a well-defined layer because it was discovered very late on in life, but it's in the very deep stroma. It's a very thin layer. It's about 15 microns. It's compact and tough. and is impervious to air and has very few keratocytes in it. Okay, here's Dua's layer. This has implications more for corneal graft surgery than for contact lens fitting. And then the fifth layer is Descemet's membrane. So Descemet's membrane is a strong homogeneous layer that constitutes the basement membrane of the endothelium. It is made up of collagen and glycoproteins. It's a very elastic layer and regenerates resistant to chemical agents, infection, and pathological process. So on the posterior surface, it has something called Hassel-Henle bodies, and these increase with age. The Hassel-Henle bodies are glycoproteins that adhere to the Descemet's membrane. And the sixth layer is the endothelium. The endothelium is composed of a single layer of hexagonal cells that cannot regenerate. As we get older, there is a decrease in the number of cells, and as a result of this, the existing cells, they just get larger and they fill the gaps between the dead cells and the live cells, and they basically take up the slack of the barrier function because the endothelium acts as a pump to maintain corneal detergents, and corneal hydration. So if the pump of the endothelium doesn't work, this leads to damage of the cornea by edema. Okay, so now the next adjacent structure to the cornea is the limbus, and the limbus is also important in contact lens fitting because of its anatomy and structure. We know it's a semi-transparent transitional zone between the cornea and the sclera. It's approximately 2 millimeters wide and has two layers, an epithelium and an underlying stroma. It is rich in blood vessels and lymphatics, and included in its functions are nourishment for the peripheral cornea, removal of aqueous humor, and regenerating epithelial cells. So when you look at the limbus under your slit lamp, you'll see these peg-like structures called the palisades of Voigt. The palisades of Voigt are about 1.5 to 2 millimeters apart, and this structure houses the blood vessels and lymphatics and nerves in the limbus. When neovascularization of the cornea begins, it often stems from the palisades. How does the cornea get its blood supply and nourishment? Well, that's easy. It's avascular. However, there are small loops derived from the anterior ciliary vessels that invade the peripheral cornea for about 1 millimeter, and these provide nourishment to the peripheral cornea. But these loops are not actually in the cornea itself. They are in the subconjunctival tissue, and this overlaps onto the cornea, but it's not in the cornea. Nourishment, we know, of the cornea is from tears and from aqueous humor mostly. Corneal innervation is important, and the cornea gets its innervation from the first division of the fifth cranial nerve. So these are the long and short posterior ciliary nerves. There are 70 to 80 nerve trunks that pierce the cornea in about the middle third, and then they move upwards towards Bowman's membrane, and they terminate among the epithelial cells. The nerve endings enter radially, and about 1 millimeter or 2 from the limbus, they lose their myelin so that the cornea can maintain its transparency. It takes about 9 months for these corneal nerves to regenerate once they've been damaged. The absence of innervation can be a problem and can result to a decrease in the adhesion of the epithelial cells and will result in corneal decompensation. Pardon the typo. The central cornea, of course, we know is the most sensitive part of the cornea. Okay, so we can move forward now into the specialty contact lens fitting. All right, so as I mentioned before, we're going to talk a little bit about hybrid lenses, about specialty silicone hydrogel lenses, RGP, sclerals, prosthetics. I'm not really going to go too much into aphakic fitting because because you would use the lenses that I mentioned above to do aphakic fitting. So this one, some of you, or maybe most of you, may be familiar with, because these are locally available lenses. Hybrid contact lenses are a combination of rigid and soft lenses. Most of these designs have a rigid center and a soft skirt around it. So the soft skirt allows for stability of the lens and a good centralization and better comfort, whereas the rigid center allows for better optics. The patients most suited to these lenses are patients with mild irregular astigmatism or early or mild keratoconus. Examples of these lenses on our market are the Synergize range of lenses and the clear cone lens. Okay, so customized soft lenses. So these are soft lenses that are customized for the patient. Now, examples of this are Kerasoft and Novacone. So these are not actually hybrid lenses, but these are silicone hydrogel lenses that are made a little bit with a slightly stiffer material, so to speak, and offer better visual correction. We use these when patients are intolerant to RGPs. I must admit that I don't actually use these much anymore, and neither do I use the hybrid lenses that much anymore. I tend to use the scleral lenses more often these days. So patients who fail on RGPs and hybrids usually do relatively well on these lenses here. Indications would be keratoconus, pellucid marginal degeneration, and irregular astigmatism. Okay, so RGP lenses, which we all are expert at from our final year optometry and third year optometry. There are proprietary lenses on the market like Rose K, another brand called So Clear, and another one called Ample Eye. So the one that we're most familiar with is the Rose K set of lenses. So it's a series of proprietary lenses that are suitable for keratoconic and abnormal corneas. And then there's custom-made lenses, and there's a few labs in South Africa that do custom-made lenses. This list is not exhaustive, so there may be some that I may have missed, but the ones that I've worked with are basically Inocon, which used to be Genop, and the Contact Lens Lab of South Africa. Tony Vine's lab may still be functional. I haven't really worked with them in a long time. And now let's talk a little bit about scleral lenses. So scleral lenses they are also proprietary lenses. That means preformed lenses. And then there are also custom-made lenses available. The preformed lenses are the Zen lens and the iSpace lens. The Zen lens, I think, comes from Danker Optical, manufactured by a company called Alden Optical in the US. And the iSpace lenses are supplied through Innovative Contact Lenses, and I think in Australia those lenses are manufactured. And the Contact Lens Lab of SA has a whole series of different designs of lenses that they will custom make for you. So, going back to scleral lens designs now, I'm just going to talk about the basic anatomy of a scleral lens. A basic anatomy includes a haptic zone, which is the scleral landing zone, a transition zone, indicated here, and an optical zone that helps to correct vision. So we're going to discuss a bit about how the lenses are designed and what we can and cannot do, and some fitting issues. I'm not going to deal with fitting in detail because that on its own is like a 5 or 6 hour lecture. But I've selected aspects of contact lens fitting, which I've lectured to students that may help you to get started if you'd like to start fitting scleral lenses. So the optic zone can either be spherical or aspheric, and aspheric designs have obviously less aberrations. The back surface.
I didn't catch that.
Ooh, Siri wants to talk to us. Let's put Siri off. Apologize for that. So when we're dealing with the back surface of the lens, the back optic zone radius is what gives us the power. The principles that you use in determining the back optic zone radius are the same principles that you use in fitting an RGP lens, right? The idea is to create a nice even post-lens tear layer so you get the best vision correction properly. These lenses vault the cornea. They don't actually rest on the cornea. But you do get mini sclerals, or what we call corneoscleral lenses, that sometimes are fitted with feather touch, so they may actually bear slightly on the central cornea. When it comes to determining power and adjusting making adjustments to the back optic zone radius, changes in the post-lens fluid shape are the same as when you're dealing with RGPs. So in other words, if you make a 0.1 millimeter of radius change, it produces a 0.5 diopter change in the power. For example, let's say you have a plano lens, your fitting lens is plano, and the base curve is 7.7. You now want to change that base curve to 7.8. So we are actually going flatter, and if we go flatter, we are making it a little bit more minus. So that change from 7.7 to 7.8 millimeters creates that changes that lens from plano to minus 0.50 in power. All right, so let's talk a little bit about the transition zone of the lens. Not all lenses are alike. Some of them have more than one curve in the transition zone, as you can see on this slide over here. The transition zone is the one that actually sets the sagittal height because it connects the landing zone with the optic zone. And this is the zone, this is the curve that actually, or the zone of the lens that actually helps to vault the cornea. Some designs just have one curve, one type of curve in the transition zone, whereas others may have a combination of curves in this area that help to create more lift. Now, if we're talking about the scleral landing zone, which is also referred to as the haptic zone, so we're talking about this area here now on this OCT image. The principle involved is to align the lens to the shape of the sclera when we're fitting scleral lenses. The limbal shape, yes, when we're fitting corneal scleral lenses, sorry, this bullet is not meant to be here. So in a scleral lens, it rests mostly on the sclera, so we want to align to the scleral shape, but in a corneal scleral lens, it kind of rests in between the cornea and the sclera, so it may be on the limbus, and then we align to the limbal shape. It is defined as a flat curve, or it also may be a series of curves, and the width of the scleral landing zone could be about 3 millimeters or more, depending on how you're fitting. Okay, so let's talk about toric curves on the scleral lens a little bit. If we put a toric scleral landing zone on the contact lens, when would we do it? Well, when we want to improve the fit of the lens. It doesn't really do anything for the vision because it's not in an optical pathway. It helps to decrease bubble formation. It helps to decrease conjunctival compression by the contact lens. And the larger the diameter of the lens, the greater may be the need for a back toric design to stabilize that fit, because the sclera becomes more toric as you move away from the cornea. Front surface toric designs, now these are meant to correct vision, to improve vision. And just like with a normal RGP, it may require putting a bit of prism ballast in the lens to stabilize the fit. It can also be used in combination with the back toric curve to stabilize the fit. There are also bifocal designs of scleral lenses available. These are usually based on the simultaneous vision principle. It helps in that because the lens is so stable and hardly moves, it gives you much better stability in the vision, particularly because it doesn't move much in the pupillary zone. The optical quality is usually better than with soft lenses, but in patients who have pathology, doesn't always really work very well. Okay, and then if we talk about that scleral landing zone a little bit further and we refer to the edge profile, now you may have the best fit of the lens, but the edge profile influences comfort on a lens, and the same can be said for corneal RGPs. In this slide, in the first image here, you can see that this edge is quite thick and it is pressing into the underlying conjunctiva. So this will cause conjunctival blanching, so it restricts the blood flow, which you'll see on a slit lamp quite easily. So you don't need to have a OCT to view this. An optimal edge is one that just rests on the conjunctiva, all right, so that it doesn't actually put pressure on the blood vessels. So let's talk about the materials of a scleral lens. Well, the scleral lenses are usually a little bit thicker than conventional corneal RGPs, so it can range from anything from around 300 microns to about 600 microns. We prefer to have thinner centers rather than thicker centers to allow for better oxygen permeability to the material. We almost always make them from high decay materials, unless of course they are trial fitting lenses that you use in your rooms. Then you want a more robust material. Suitable materials include Boston XO, which has a decay of 100, Boston XO2, which is a decay of 141, and materials like Optimum and Optimum Extreme. There is very, very little to almost no tear exchange underneath the scleral lens. So the limbal and conjunctival vessels are quite influential in contributing some oxygen to the tear lens that stays underneath the contact lens. The lens thickness needs to be sufficient to prevent warpage of the lens, but also it needs to be not too thick to decrease the amount of oxygen that gets to the cornea. Remember, when the patient is wearing a scleral lens, oxygen must pass through the lens, then it must pass through the tear lens before it actually gets to the cornea. So there's quite a few barriers to oxygen getting to the cornea. Scleral lenses you can have wettability problems with patients wearing scleral lenses. This is particularly so in people who have very high allergic reactions, lots of atopy, so lots of mucus being produced and lots of lipid in the tears, etc., etc. So this starts adhering to the surface of the lens. This can be improved by plasma coating a lens, but plasma coatings wear off with time. Right? So some lenses can be recoated. In our country, it's not an easy process to do because you'd have to send it off to another country to get it done. It is also important to try and manage the existing disease in the eye when you're fitting patients who have these kind of issues. Okay. The experts recommend changing of the scleral lenses approximately every 2 years. I found that it's not always necessary, but the reason for this is because these are very, very large lenses. They tend to warp a little bit because of wearing, because of the way it sits underneath the eyelids and the palpebral aperture, etc. So you'd have to monitor to see if you're getting any astigmatism that wasn't there previously coming through. Now, fenestrations sound nice and romantic, but I don't really actually like them. I don't actually fenestrate many lenses ever, because fenestrations sometimes create more problems than they help. Non-fenestrated lenses, however, tend to float more on the eye, while fenestrated lenses tend to sink more on the eye. The clearance in fenestrated lenses is much, much lower than in non-fenestrated lenses. So if you put a non-fenestrated lens and you get a clearance on the cornea of between 2 and 600 microns, that will then drop to between 100 and 200 microns in a non-fenestrated lens. Fenestrations can cause air bubbles. It can result in debris accumulating on the lens, and the conjunctiva can get sucked through the fenestration, creating a problem. We usually, though, when we do place a fenestration on a lens, we do it over the deepest pooling area. So this slide is depicting lenses with fenestrations in it. And you can see this lens here. We don't usually put more than 4 fenestrations on a lens because then that weakens the structure terribly. You can see this is a scleral lens fitted here with touch, with central bearing. This one here, there's a fenestration over there, but this cornea looks quite nice and quiet. And you can see here where this fenestration is, there's a bubble forming on that lens. Okay, so let's talk a little bit about the fitting technique. Okay, So we don't really need to do keratometry when you're fitting a scleral lens, because you're not fitting on the cornea, you're vaulting the cornea. But you need to know the sagittal height. Because that's what is important in fitting the, well, not need to, but you need to end up with a decent sagittal height from the cornea. The sagittal height is dependent on the lens diameter and on the radius of curvature, the corneal asphericity, and the shape of the anterior sclera. If you have an OCT on hand, you can use this to nice and accurately determine your starting point for your contact lens. But if not, you can use the Smith technique, which I'll demonstrate to you shortly. So this is an OCT image here. And how you use an OCT to determine the first selection of the best lens is using the OCT, you can determine a chord length of about 15 millimeters, and then you measure from the apex of the cornea to that 15 millimeter chord, and that helps you to get a better idea of the vault height that's required for the scleral lens that you're going to start with. The OCT also helps you to look at the tear layer thickness. When you trying a lens on the patient's eye, it helps you to assess the fit of the contact lens versus the corneal shape. It helps to measure the thickness of the cornea, and it helps to determine limbal clearance and to visualize scleral lens edge profile. So this is a Smith technique, which is a technique to estimate the anterior chamber depth pretty much. You put your slit lamp on medium magnification, your observation angle at 60 degrees, and you swivel your beam from vertical to horizontal. You put you open the slit to about 2 millimeters, and you focus this on the corneal surface. So if you can see the room lights are off here, right? But here's the margin of the pupil, right there, and this is coming in at this beam is coming in at your 60-degree angle from your slit lamp. This is a reflection of the light in the pupil, right? So remember now, what you want to do is open the slit on the slit lamp so that the two beams just touch, and then you read off the measurement from the slit lamp. So it may have gone from 2 millimeters to 3 millimeters, and then you multiply that by a factor of around 1.34, and that gives you an estimate amount to work with. I usually add another 300 microns or so on, and then that's the lens of first choice that I start with from my trial fitting set. So the 5 steps that are important to bear in mind when you're fitting a scleral lens is take into consideration the lens diameter and the optic zone, establish the central and limbal clearance, establish scleral landing zone alignment, make sure that there's adequate lens edge lift, and you need to consider whether or not you need a toric design anywhere on that lens. Okay, so how would you work out what diameter of lens you require? Well, that's pretty much what you as a practitioner prefer in the end. Some people prefer working with larger lenses. I work with a variety of diameters. What are the things to consider? Consider how much clearance you require, because larger lenses typically offer a higher sag. Consider comfort. A greater bearing area on the sclera allows for less pressure on the conjunctiva and may be more comfortable. So smaller lenses sink into the conjunctiva, sorry, not the cornea, but into the conjunctiva more. And there's also less movement of the lens. So with a larger lens, you can get a little bit of movement, and a little bit of movement can encourage a little bit of tear exchange. The larger lenses, if it's too large, it'll tend to decenter a little bit more temporally, because the nasal sclera is flatter, so it pushes it temporally. And then consider the palpebral size of the patient, whether they have loose or tight eyelids, and the ease at which they're going to be able to handle putting this lens on. All right, so smaller lenses may be a little bit easier for patients with smaller palpable aperture sizes. This is a table which I drew up a little while back, which basically summarizes the lenses and the designs that are available. But this is a dynamic thing, so this is not exhaustive. It's nothing that I haven't mentioned to you already. This is the 3 labs that sell scleral lenses in South Africa. These are the products that they sell, and this is the approximate HVID for that particular lens or product, and these are the recommended diameters for that size of HVID. So if you have a patient who has an HVID of HVID being horizontal visible iris diameter of 11.7, the required diameter is estimated at 17 millimeters. This is not necessarily the case. I very rarely fit lenses that big. Most of the lenses that I fit are between 15.5 and probably 16.7, 16.8 millimeters in diameter. I have fitted larger lenses, but most of the time it's not really required. Okay. So we spoke about determining diameter. Now let's talk about the optical zone, optical clearance zone. It's also called the optical clearance zone. So most of the lenses that are made have a fixed optic zone diameter. In determining or adjusting the optic zone diameter, you want to consider the pupil diameter, the depth of the anterior chamber, and how and when the lens decenters. The clearance area is the optical zone plus the transitional zone on the lens, and this should be made about 2 millimeters larger than the corneal diameter. This is to allow for adequate lumbar clearance. If the optic zone cannot be adjusted on the lens, then it may be an idea to change the overall lens design or to use a larger diameter lens. So going back to the optic zone diameter, most of the preformed lenses have an optic zone diameter of about 9 millimeters, but I have found that I've needed to vary the optic zone diameter up to about 10 millimeters in certain patients. Okay, so when it comes to determining the clearance of the contact lens, so how thick should be the tear lens underneath the scleral lens? Well, again, it will vary depending on your patient, depending on the pathology that you're using and that patient has, and the lenses that you're using. There's no absolute rules, but the guideline is to get a clearance of between 100 and 150 microns. In the early days, they used to say keep it at around 300 microns, but that's not always the case anymore, because the thicker the tear lens, the more difficult it's going to be for oxygen to get to the cornea through the contact lens. Corneoscleral lenses, because they move a little bit more and they're a little bit smaller, can be fitted with a much lower clearance, between 20 and 50 microns of clearance. Larger lenses can be fitted with between 2 and 300 microns. They may be sufficient for that, but some are fitted with even more. Keratoconics may need a higher sag than post-graft patients or post-refractive surgery patients, where their corneas are actually a little bit flatter. And think about the ocular surface disease that's present. What kind of sag would you fit that person with? But I try not to keep the sags too high, because you don't want to encourage conjunctival tissue to prolapse underneath the contact lens, and we don't want too much of debris accumulating underneath the contact lens. So this is a nice slide indicating clearance. Now, in this slide, this area A this is an OCT image, but this area A is supposed to indicate bearing of the contact lens, but it got cut off. So in this slide here, you can see with this OCT, they measured approximately 1.6 microns of clearance under the cornea, which in this, they talk about good clearance being 1.66 microns. And here, at 300 microns is considered excessive. But like I said, it will vary from patient to patient. Okay, so when you're starting to determine what the clearance should be, or what the sag, you start with either a high sag or a low sag based on your calculation from the Smith technique, I start about maybe 100 to 200 microns higher than what my calculated lens of first choice is. And then you would obviously adjust till you get the suitable clearance that you need under the lens. When you're inserting the lens, you must use preservative-free saline and lots of fluorescein so that you can actually visualize the tear lens underneath the scleral lens. When you're inserting, make sure there are no bubbles. And when you have an ideal optic zone fit, you'll see a nice equal green fluorescein pattern with no areas of bearing. So bearing looks like black on the image as opposed to fluorescent green. Okay, fluorescein we know becomes visible at a minimum tear lens thickness of 20 microns. So if you're not seeing any green, that means there's less than 20 microns of fluorescein in that zone. And this slide indicates that to us. So here, you can see here's the limbus. This nice thick green band here, which means that there's good clearance over the limbus. Whereas in this slide here, in this image, there's black here, which indicates that it's clearing in over the cornea, but over this peripheral cornea and the limbus, there's bearing. In this slide, you can see this is the cornea. Okay, here is your tear lens with loads of fluorescein in it, and this is the lens thickness. You can see that there's an even thickness of the lens to the tear lens. That's how you ideally want to fit the lens. Sometimes when the sag is too low, you'll get bearing on the central cornea. You can get bubbles, right, that come from incorrect insertion, or you can get bubbles accumulating under the lens from excessive corneal, the edge is lifting, right? So there's too much bearing and there's edge lifting, so it's introducing some air underneath the contact lens. And also because of the toricity of the scleral surface. Excessive clearance may cause a decrease in the visual acuity. However, in keratoconic patients, you may need a higher sagittal height because you get a very uneven tear lens thickness. As I mentioned previously, you can fit the lens with feather touch, where there's very marginal clearance, so it's just about bearing over the cornea. The goal is to get the minimal sagittal height that vaults the cornea with marginal or no corneal bearing. Minimal bearing appears to be better tolerated in sclerals than in people who wear corneal RGPs because there's less movement of the lens and hence less irritation to the cornea. During the fitting of lenses, you need to obviously let the lenses settle on the patient's eyes. So it's a very time-consuming process. I allow the patient to sit for at least 40 minutes. Very rarely do I actually let them sit for anything less than that before evaluating the tri-lens. The reason for this is because I found many patients, during this settling time, the contact lens drops by about 100 microns or more. So you want to get the closest fit to what it's going to be like in the real world. Okay, so I've shown you this image before with illustrating the lens thickness, the tear lens thickness, and the corneal thickness. And I've mentioned all of these things to you before. So to get this image, you're simply going to use the optic section at 45 degrees on your slit lamp. And you need a dark room for this. And you evaluate using white light, not blue light. Limbal clearance is very important, and that's why we spoke about the anatomy of the limbus for a little bit, right? So base curves that are slightly flatter than the K help to create a little bit more clearance in the limbal zone. And if the sag height is also dependent on the lens diameter. So a larger lens diameter will result in an increase in the sag for a particular base curve of lens. All right, so we don't want bearing on the limbus because of the limbal stem cells and because of regeneration of corneal epithelium. We've said that many times. We want an approximate clearance of about 100 to 150 microns. And when you take the lens off, when you're doing your aftercare and your assessment, there must be no staining over the limbus. Right? So corneoscleral lenses don't always clear the limbus. Sometimes they rest on the limbus, but because they move a little bit more and there's better tear exchange, it's usually fairly well tolerated. If you get persistent bubbles in the limbal zone, you can eliminate this by flattening the base curve a little bit so it creates a better lift, or fitting a lower profile limbal zone curve. So when you're assessing the scleral landing zone alignment, you use your slit lamp or again your OCT. To use the OCT, you can take an image and it'll be quite easy. With the slit lamp, you are looking for a ring of bearing on the inner aspect of the landing zone. So this will indicate that the scleral landing zone is too flat. If there's air bubbles or frothing at the periphery, it also indicates that your landing zone is too flat. If there's bearing on the outer aspect of the landing zone, it will increase the overall vault of the lens. If there are areas of whitening underneath the scleral landing zone, this indicates that there's blanching of the conjunctival vessels and there's too much compression from that landing curve. So the scleral landing zone alignment is related to how the how much clearance you have underneath the lens. If the zone is too steep, it will lift the lens, creating more clearance. And if there is marked central corneal touch, the landing zone may be too flat, so it will be elevated off the corneal surface. The scleral surface. The goal is to create alignment as far as possible between the corneoscleral or scleral zone. This OCT image, OCTs are very useful in actually assessing the fit of a lens. So this image shows you how the scleral landing zone is aligned here. This is the limbus, so it's vaulting the limbus nicely. This part of the image is a little bit dull, but you can see that there's a nice tear lens here. It's a thin tear lens. It's probably about 100 microns or so, this tear lens. This is also a nice to look at image. You can see how irregular this cornea is. There's a nice regular scleral lens, and you can see that this very irregularly shaped cornea in a keratoconic patient creates a very strange and irregular tear lens, right? So this is a minus tear lens because it's thinner in the center and thicker in the edge. So the overall power on this scleral lens will probably be fairly high minus. But this person's cornea is very distorted. You can see that even from the posterior surface of the cornea, there's a really strange curve going on there, right? It's not nice and smooth and spherical or even aspheric. This person probably has formed keratoconus, which means that there's thinning from the posterior surface of the cornea. So in a patient like this, right, if you see an image like this, expect that there will be quite a bit of residual astigmatism that you can't quite correct for. So you may be limited in how much, in what VA you get with this person. Probably be able to improve it with a pinhole, but not with the contact lens, or even not with a combination of glasses and contact lenses. So you assess the scleral landing zone of the lens with its alignment to the conjunctiva, and you look for blanching and for conjunctival compression. Blanching is when the blood is pushed out of the blood vessels, but compression is where you see a kind of a little indentation, but it doesn't really push the blood out of the blood vessels. While compression may be acceptable in some cases, sometimes it does cause a little bit of hyperemia. If the lens is pinching on the conjunctival tissue, this will cause impingement and will exhibit staining when you take the lens out. Long-term impingement can result in conjunctival hypertrophy and scarring. Larger lens diameters have less weight on the sclera and therefore may help to reduce this. Okay, so, oh dear, the resolution of this is not the best. In fact, it's quite bad. but it's an illustration. It's of how the scleral landing zone here is way too steep and causing conjunctival blanching, and it's pushing blood away from these zones where the lens lands. We call this toe blanching because it's on the peripheral part of the scleral landing zone. Okay, so when we talk about the edge now, looking at the edge and edge alignment, too much edge lift causes discomfort because when the patient blinks, they feel it against the eyelid, and there's a lot more lens awareness. Low edge profiles can cause impingement on the conjunctiva and obstruct blood flow, which was what we just spoke about. So observe the edge using white light and check if it sinks too much or it lifts too much, etc., etc. And most of the manufacturers will allow for a couple of different edge profiles designed, so you can adjust accordingly. Front surface torics we already spoke about. You could put a front surface sill on the lens, which would require a bit of prism ballast to stabilize it a little bit. And you would, in determining the axis, you'd use the Lars rule as you would do with the rest of contact lens fitting. So in general, some useful things to remember is that scleral lenses typically don't move much at all, but they should move a little bit when you push it up with your finger. Okay. Changing the lens edge does not impact on the lens movement. If the lens has too little apical clearance, it may vault across the corneal apex or along the flat meridian on a toric ocular surface. And to optimize the lens fit first before you do an over-refraction to determine the power. I prefer to do a trial frame over-refraction as opposed to using a phoropter, because a trial lens mimics the real world better than a phoropter does, in my opinion. This is a scleral lens fitting scale that was developed by the Ferris State University in Michigan. This is the same image that I showed you twice already. And in the scale, there's a clearance of 50 microns indicated here. If you look closely, this is the tear lens, and this is the anterior surface of the lens. Here we have 150 microns. 500 microns, and here you can see the cornea is about 500 microns thick. And here we have 600 microns. So you can see that this tear lens is double the thickness of the lens. This is the same scale as we've just looked at now that indicates the vaulting of the lens. This is the limbal vaulting scale, and here is the edge relationship scale that you can use to assess how your lens is fitting. Okay, so time for a break. We can take a few questions now.
Okay. I have noted a few questions. I think there were just two in the meantime as the colleagues are typing. The first one was saying, what are fenestrated lenses?
Okay, so I apologize for that, for not explaining fully. A fenestrated lens is a lens that has a little hole drilled into it. So fenestration is a hole. That's pretty much it.
Okay, then the next one was saying that what is the need for fenestration on scleral lenses?
The need is when you want to allow more oxygen underneath the lens in most cases, and you want to get a lower alignment. So because of very distorted shapes in the cornea, sometimes you get large areas of pooling underneath the lens. So can I go back to a slide?
Yeah.
Okay, so let's go back to a slide here, and I'll show you the image of the fenestrated lens again there. Okay, so if you look at that image there, you'll see where the fenestrations are. Because of the fitting philosophy of the way this lens was fitted with central bearing, right? So, and there's deep areas of pulling. There's probably a very steep cornea. So the fenestrations were put in to try and improve the oxygen permeability in that area, because the tear lens would be very thick in that area. Okay, I hope that addresses it.
Okay, then the last question that I see here says, how can we make scleral lenses to be more accessible for both practitioners and the general public, not to be limited by cost?
Oh, that's a tough one because that's an economic question, and we having economic crises right now.
Yeah.
There's really not much way to do that, I use locally manufactured lenses because that is a little bit cheaper for the patient than using lenses that are imported, and also it's a little bit quicker because imported lens will take longer to get to you. It's also cheaper to use a locally manufactured lens because you can adjust it. Certainly not cheaper, but more convenient. So if you need to make certain adjustments or to specify certain parameters on the lens, you can do that at less of a cost issue, than you can if you're buying a pre-made lens out of the country. But having said that, I have fitted proprietary lenses because if there's a lens for every patient, and even the custom made lenses, sometimes you can't custom make it to exactly what you need, and a preformed lens may actually work better. But there's no way, in short, there's no way to keep the cost down that I am aware of, right? Because it is an expensive product, unfortunately. We can ask President Ramaphosa to help subsidize scleral lens patients, I think.
Okay, I see there's a couple of questions that are coming in. Let me just read. I think there's about 2 or 3. There's one which says, what is the usefulness of scleral topography in scleral lens fitting? Is there a scleral topography and corneal topography, or is it one thing?
No, it's not one thing. So this is scleral, and we're talking about scleral and corneal topography.
Yes.
So it's not that easy to actually determine scleral topography. It would be wonderful if we could, because then we could custom make the periphery of that scleral lens to fit nice and comfortably on the sclera. Corneal topography is topography of the cornea itself, so it doesn't extend beyond, I think it's usually the first probably 6 to 8 millimeters that are most accurate on a topographer, corneal topographer. So that helps to align your optic zone, your back optic zone radius, so that you get the best possible vision from that information. But scleral topography would have the benefit in improving the fit of the lens and the stability of the lens. We don't really have instrumentation to do that yet, but I can see it as a forthcoming attraction because scleral lenses are growing constantly. It's very dynamic. And so the technology is growing constantly, So yeah, I think it's a thing that will come. I know that there's research and development being done on it, but at this point, I'm not sure how far along it's gone.
Okay. There's 2 more. So the second last one is, in which cases or conditions would fenestration be recommended?
Okay, I think I've sort of answered that already, right? So you can't really tell, but you got to put the lens on the eye and see if you need it. I've probably only fitted a fenestrated lens once, and at that, not a fenestrated scleral lens. I've fitted a fenestrated RGP lens, right? It didn't really make any difference to what I was hoping it would. I do know other practitioners who fenestrate lenses often. I think it's also your approach to fitting lenses, and what you've been exposed to in your learning.
Okay. The last one for this session now is, what is the relationship between a base curve and lens power?
Base curve and lens power. The base curve of the lens, I explained that before, as with RGPs. If you have can I ask the person to be a little bit more specific, right?
Okay.
About the question, because I did explain that when you determine the base curve, you select the base curve how you would select for an RGP lens, right? That's your lens of first choice. And when you make adjustments in the base curve of 0.1 millimeters, that would imply a change of 0.5 diopters in respect of the power change. So if you're going flatter, then you're probably inducing minus. of minus 0.50, and if you're going steeper, then you are increasing the power by plus 0.50 diopters.
Okay.
Okay.
I think, let me see, there's one more. What are the benefits of using topography in scleral fitting?
None, really, except if you're doing topography just to monitor the curvature of the cornea. It's not in the scleral lens fitting itself, it doesn't really have any value.
Okay, I think that is it. You may proceed.
Oh, sorry, wait, let me go back a step there, right? It has
Okay.
very little value because you can use it to determine if there is warpage on the contact lens, right? So it'll give you, so after you put the lens on the patient's eye, you do topography over that lens, and that will tell you whether the lens is warping a little bit, because you'll get some astigmatic changes that would not be there if the lens wasn't on the patient's eye. I also use an autokeratometer for that. So when I put the patient's lens on the patient's eye, I then do autorefraction over the contact lens, and that helps to make the over-refraction a little bit quicker, and I check for, I do auto-refraction and autokeratometry, and I check for warpage on that lens. So anything more than 0.5 diopters would be concerning. Usually, I have not had anybody who's had that much warpage on the contact lens.
All right. I think that's it. Just to remind colleagues that I see some of the colleagues are dropping. I don't know if it's connectivity issue, they're just deliberately leaving. You only get points for the session if you stay the full session. So we will monitor that just as a reminder. Please proceed, Ms. Naidoo.
Okay. Whoops, let me go forward a bit. Okay, just give me 1 second. So this is the easy part of the presentation now, talking about therapeutic contact lenses. Okay, so when we're fitting a lens therapeutically, the goal is to maintain or restore the integrity of ocular tissue. The aims of therapeutic fitting are to relieve pain, to promote healing, to mechanically protect and support the cornea and the eye, and to maintain corneal hydration. It is also used for drug delivery and with new technology to monitor IOPs and sugar levels. Corneal defects that are indications for therapeutic contact lens fitting include recurrent corneal erosion, filamentary keratitis, Ferguson's SPK, Stevens-Johnson syndrome, exposure keratitis, entropion keratitis, dry eye syndrome, corneal perforation, and bullous keratopathy, and chemical burns. So we're going to deal with each of these and see how contact lenses can be used here. So corneal abrasions are scrapes or scratches or cuts on the cornea. You can get corneal abrasions in epithelial basement membrane dystrophy, in posterior marginal blepharitis, and also post-refractive surgery, particularly in PRK. Patients present with symptoms of pain on opening the eye when awakening, lots of watching eyes, lacrimation, foreign body sensation, and they particularly say that the eye feels stuck in the morning, and blurred vision. So here we have some images of corneal abrasions. There's a nice inferior abrasion on this image here, and this image here is a scale indicating different degrees of SPK. We'd use preservative-free tear supplements to treat corneal erosions and corneal abrasions, and a bandage contact lens. So the bandage contact lens is your therapeutic lens. Patients who are unresponsive may require stroma micropuncture or delamination with alcohol. The bandage contact lens that you use should ideally be a silicone hydrogel contact lens with a high or mid water content, or a mid or high water content hydrogel lens, but the silicone hydrogel lenses should be high DK lenses. The duration for which you would fit the patient with the lens would depend on the healing process. Filamentary keratitis. Now, here you get mucus filaments that adhere to the cornea. This is associated with very severe dry eye syndrome. It can be associated with corneal surgery, and it can be made worse with soft contact lens use because the filaments adhere to the contact lens, and it may also recur. I had a patient not very long ago who presented with this feature, and he was treated with topical steroid eye drops for this condition. But he had a corneal graft, and what was happening was he had developed superior limbic keratoconjunctivitis sicca. So just underneath the top lid is where he had filaments, very much like the slide that's presented here. He was treated with a N-acetylcholine, which is an anti-mucolytic to break down the mucus strands, and we then fitted him with a soft lens after that to just cover and protect the cornea for a little bit. He does need to wear scleral lens because that will offer him more protection of the cornea. The symptoms that they present with is always pain that ranges from mild to severe. Usually they'll come in when it's severe. There's photophobia, there's the foreign body sensation, and the eye is usually red. This is another image of filamentary keratitis. Again, I said anti-inflammatory eye drops, and it's managed by the ophthalmologist. Topical steroid eye drops, preservative-free lubricating eye drops and ointment are extremely useful. The patient can be fitted with punctal plugs, and the scleral contact lens can be used in the long term, while a silicone hydrogel lens can be used in the short term to protect the cornea. Thigason's SPK. So Thigason's is a relapsing and remitting SPK, which means it waxes and wanes. It comes and goes. It is idiopathic, so there's no good reason for why it happens. The symptoms that patients present with are photophobia, watering eyes, foreign body sensation, and very mild blurring of the vision. So they have this haze in the vision. You can fit them with a silicone hydrogel bandage contact lens. They can be treated with steroid eye drops, but the most useful thing usually is profuse tear supplementation. Stevens-Johnson syndrome, it's very rare that we would see these walk into our practices. In fact, probably never. This is a rare but a serious disorder of the skin and the mucous membranes, and is a reaction. It's like a very severe sort of allergic reaction to medication. Patients present with fever, conjunctival injection, and erythematous rash on the body. You can get severe corneal and conjunctival epithelial defects. It requires medical management, but large scleral lenses may help to prevent symblepharon formation and help to preserve the fornices and protect the cornea. Let's go back to that slide. You can see in this slide, this youngster is fitted with a scleral lens here, and you can see that there's damage to the cornea there. Exposure keratitis, so corneal exposure. The cornea gets exposed when there are eyelid lacerations. There may be a coloboma of the eyelid, lid retraction. There could be an entropion or an ectropion. There may be hepatic keratopathy or proptosis. Again, signs and symptoms include pain, photophobia, lacrimation, foreign body sensation, and blurred vision. The best treatment is to lubricate the eye profusely, so lubricating eye drops and ointment, punctal plugs, moisture chambers, and bandage contact lenses or scleral contact lens will help to protect the cornea. Here, this is a severe dry eye syndrome. This is what the cornea looked like before, and this is what it looked like after fitting with bandage contact lens. And the same in this image here. Okay, so everyone knows about entropion and trichiasis. Entropion is when the eyelid turns inward and the lashes rub against the cornea. Trichiasis is an anatomic misalignment of the eyelashes and results in the eyelashes rubbing against the cornea again. It does cause recurrent corneal erosion because it recurs. Symptoms are pain, lacrimation, and foreign body sensation. How is it managed? When in the long term, surgical management is indicated for...
Okay, I found this on the web for when was about intro.
Okay, sorry, Siri wants to talk to us again. I apologize for that. I was saying long-term surgical management for ectropion, bandage soft contact lenses for the short term. You can use hydrogels or silicone hydrogels. And if patient cannot have surgery done, then maybe a scleral lens for the medium to the long term. Corneal perforation and descemetocele formation. Well, this can occur from trauma, from infections or inflammation. Descemetocele is a herniation of an intact Descemet's membrane through a stromal and epithelial defect, as seen in this slide here. Okay, the patient will have severe pain, a sudden drop of vision, and of course excessive tearing. It'll be hard to actually get them to keep the eye open. This also requires ophthalmological management with topical and or antibiotics, intensive lubrication. It may require tarsorrhaphy. Tarsorrhaphy is when the eyelids are sewn shut for therapeutic purposes, temporarily sewn shut for therapeutic purposes. It may require anti-inflammatories, both topical or oral, and a bandage contact lens to promote healing and reepithelialization. And it may also require surgery. Bullous keratopathy you are likely to see in your practices, where the cornea becomes swollen, cloudy, and blister-like in appearance. The endothelium is decompensated and it results in folds in Descemet's membrane and hence stromal edema. Microcysts then form from the intracellular epithelial edema. This is associated often with Fuchs endothelial dystrophy, with cataract surgery, and with glaucoma. The patients present with severe pain, with photophobia, and with blurred vision. The slide here depicts bullous keratopathy. So you can see the bully on the surface of the cornea, and you can see how hazy this cornea is. We typically use dehydrating agents such as 5% sodium chloride or natrium chloride, drops or ointment to dehydrate this cornea, and then you need to treat the underlying cause. So if the underlying cause is glaucoma, you have to manage the IOP. You can use a bandage contact lens in mild or moderate cases, not in advanced bullous keratopathy. So chemical burns, again, contact lenses are used to help protect the cornea here and to promote healing. In the early stages, we can use a soft silicone hydrogel lens, or you can use a large scleral lens. Now, in cases like this, we use some ophthalmologists, not us, but actually I don't see why we can't use it, can use something called a scleral lens ring to maintain the fornices in the eye. So I'm going to show you what a scleral lens ring looks like. That's a scleral lens ring. So a scleral lens ring basically has no corneal component to the lens. It just protects the sclera and it prevents this tissue from growing and forming scar tissue. So it prevents some blepharon formation. You can also use a very large diameter scleral lens to serve the same purpose. So in a patient like this, going back to the question about fenestrations, you could possibly put a fenestration somewhere there where there's an area of large pooling. Okay, so now coming to prosthetic lenses, prosthetic soft lenses. This is actually one of my patients who had cataract surgery that became complicated and resulted in this very large iris tear, so to speak. So he is in the SANDF and he obviously has now lots of photophobia as a result of this and lots of discomfort. So it's very difficult to even take these pictures with a flash because of the photophobia that he has. So this is a close-up of the lesion on that iris. And this is the soft prosthetic lens that we fitted him with to improve the cosmesis, but also to reduce the photophobia in that eye. So this has a clear optic center of about 4 millimeters, and it has an opaque iris periphery. And he wears his multifocals over that. Okay. This is another example. So this patient, the previous patient here, would be an example of fitting for both cosmetic and functional purposes, whereas this patient here would be an example of fitting for cosmetic purposes, but therapeutic in terms of one's self-confidence and psyche. So this young lady here is keratoconic. She is a very advanced keratoconic patient. And if you look really closely, you can see she's wearing an RGP on her right eye. And on her left eye, many years ago, she had corneal transplant done. And on her way home from work was mugged and injured on that eye, resulted in corneal graft rejection, resulted in a retinal detachment, and she had everything that could possibly go wrong with that eye went wrong. So right now she has, the eye pressure is quite high in that eye, so she's still using meds to reduce the IOPs. But can you imagine a young woman like this now, single young woman, going through life with an eye that looks like this? So we fitted her with a prosthetic lens. Now this lens has a black pupil, and so the whole thing is opaque. So it has round iris and a black pupil, and it improved the cosmesis significantly, made a huge difference to her confidence level. Okay, so the next few slides, I think the next 3 or 4 slides, are more suited to doing a lecture with students because it pretty much summarizes everything that we've spoken about. And it's also open to debate about how long you can use the therapeutic lenses for, how long you should use the therapeutic lenses for. So bandage contact lenses, basically you monitor the progress of the healing with the lens, and that is your guide. So as it gets better, you may want to cut down the use of the lens, maybe give it to them for fewer days, or you may get them to wait longer if it's taking longer to heal. I'm not going to go through this in too much detail because it's pretty much all that we've spoken about. Okay. And so, coming towards the end of the presentation, let's talk a little bit about what new technology exists in the arena of therapeutic contact lenses. Therapeutic lenses are being used for diagnosis and management of certain conditions. So there's a lens by a company called Descemet, which is a Swiss company. This lens is called the triggerfish lens. The lens has a micro, I forget what NEM stands for, but it's a microelectronic monitoring system. So it has a little sensor or sensors in it, as you can see in these images here. So the sensors are embedded in the lens, and it has this telemetric microprocessor. So this is used for monitoring the patient's eye pressures. This is an FDA-approved lens, so it's out there on the market. So it doesn't actually measure the eye pressure, but what it does is when it's worn for a 24-hour period, it monitors fluctuations in the eye pressures, because we only get to determine the eye pressure when the patient is sitting in our rooms and during office hours. Okay. The next lens that's used to monitor eye pressure is an implantable lens. So it's not a contact lens, but it's an intracorneal lens called the iMate, made by a company called Implant Data in Germany. So you can see how it's fitted, it's implanted behind the cornea here. And then you have this little electronic gadget that scans and records, transfers information from the implant to an electronic device, which can then be downloaded and read. Again, that's for monitoring IO pressure, not for measuring IO pressure. This one here, some of you may be familiar with because Chromagen also makes spectacle lenses. Chromagen, these are chromatic lenses made by, invented and marketed by 2 optometrists in the UK. One is Dave Harris, the other one I can't remember his name. Because it's on my notes, which I can't see right now. So these lenses, this is one particular color, but there's a variety. I think there's about 8 lenses in this. It helps with patients who have dyslexia and patients who have dyschromatopsia. It helps them to read better in dyslexic patients, and it is said to help dyschromatopic patients to actually improve their color vision, color perception. This lens is an implantable iris. It's actually not really a lens, but it is a silicone prosthetic iris implant. It's called the Custom Flex Artificial Iris created by a company called Human Optics, also FDA approved. You can see this individual had a severe injury with absolutely no iris visible on this eye. And here you can see that here's this implant, and the implant is sewn into place, and this is what the resulting eye looks like. That really looks awesome. But it's not just for the cosmesis, it's also for the purpose of reducing the photophobia in that eye. There are also contact lenses that have been designed recently for the purpose of drug delivery. So this one, called the hyper contact lens, is made by a company called Ion Medical in Israel. It is a hypoosmotic contact lens, and it's used to treat corneal edema. Well, the lens itself is not hypoosmotic, but what happens is it has these curves. So it has these dual base curves, and it creates a reservoir and fenestration. So you can see fenestrations here. But basically what happens is you put in 5% sodium chloride drops, and it goes through these fenestrations, and it allows for the drops to be in contact with the cornea for a slightly longer time, and it helps to remove fluid from the cornea a little bit more efficiently. All right, so then there are other lenses that are used for timed drug delivery, and usually in glaucoma as well. These are called drug-eluting contact lenses, but they also can be used to deliver antibiotics to the eyes. The principle on which it works is that they create a polymeric vehicle for the drug delivery on the contact lens. So they implant this polymer within the lens material here, and this allows for timed release of the drug onto the corneal surface, onto the eye. This is quite an interesting little gadget. This is a bionic eye. It is a miniature telescope that is made by Vision Care Ophthalmic Technologies in the US. It is FDA approved, but it's mostly useful in patients with end-stage dry AMD. In studies, it produced an improvement of about 3 lines in visual acuity. This one here is more easily accessible to us. I'm not sure about its availability on the market, but AccuView lenses by Johnson & Johnson now come with transitions on them. And these are disposable lenses, so your contact lens will get darker in the sun and help to give you additional protection from UV light. So in conclusion, I would just like to say that for successful contact lens fitting, the patient selection is important to having a successful specialty contact lens fit. The patient motivation is important. The motivating factors for patients are an improvement in their VA, an improvement in cosmesis, and an improvement in their symptoms. It is important for you as a practitioner to make sure that the patient develops a realistic expectation of the vision outcome. And you as a practitioner should have a realistic expectation of the vision outcome. In complicated corneas and in complicated conditions, you won't always be able to get 6/6. You have to take what you get, but you push so that you get the best possible VA. You need to monitor these patients with specialty lenses more closely than you monitor your other contact lenses, and you need to evaluate them more frequently for complications, and you need to manage the complications. Many of these people have accompanying ocular surface disease and atopic conditions that need management. So the contact lens is not a solution for the coexisting ocular surface disease. So you still need to keep them on the anti-allergy eye drops. You need to treat the dry eye. And I found with scleral lenses, scleral lens patients who are keratoconic and have ocular surface disease, many of them, just giving them additional lubrication over and above that scleral contact lens helps to make the lens more comfortable, and the experience with the lens is comfortable. So that's it for me, folks. I hope you've learned something a little bit, even if it's just one thing from this presentation. All right.
Thank you so much, Ms. Naidoo. I have noted a few questions as I have been monitoring the chat. So the first question, I think it was still on the issue of the sterile lenses, but I noted it nevertheless.
So
it says that, is there any multifocals on sterile lenses, or is it only in bifocals?
Very good question. When it comes to contact lenses, there's very little differentiation between bifocal and multifocals. I think sometimes we use the term interchangeably. A bifocal would imply a segment on the lens. But like I said, there's the simultaneous vision principle, right? So that is used in manufacturing a scleral multifocal lens. It's two powers. It caters for distance and near, and somewhere in between the intermediate becomes accessible as well. So it functions like a multifocal lens. Specific bifocal would be a lens which has a specific segment on it. All right. So the simultaneous vision lens is then the closest thing to multifocal and scleral lenses.
Okay.
That's my answer.
Thank you. The next one says, what SIH contact lenses is best for bandage lenses?
Okay, so the lens that I use is the Air Optics Night and Day. And because it's the highest DK lens, I like that one the best, and it comes in a plano, so I use that as a bandage contact lens. So people, most of people differ with what they use. If vision is not an issue, then you can, often Pure Vision 2 HD is used. That's approved for bandage contact lens usage. The Acuvue Oasis is approved for bandage contact lens usage. Most of the silicone hydrogels are, but I like to stick to a very high DK lens, and so I use that Air Optics Night and Day.
Okay, thank you so much. The next one says, do you administer drops on top of contact lenses?
Only preservative-free drops on top of contact lenses, unless I am co-managing a patient with an ophthalmologist around a particular issue. The reason for that is because we don't want the preservative staying in contact with the cornea for too long, because we don't want to create preservative sensitivity.
Okay. The next one says, is the contact lenses for color vision soft?
Yes, the Corneal Gen lens is a soft lens.
Okay, I see a lot of people saying thank you, very great presentation, very informative. And there's another question here, says, what happens after Descemet detects the pressure that is high? Does it keep the IOP normal?
No, it's actually purely for monitoring the IOP levels. So it's fitted only for 24 hours. It is not a drug delivery system at all. It's just a monitoring system, that's all. So it's like measuring your blood pressure. Your blood pressure machine, your sphygmomanometer, measures the blood pressure, but it doesn't influence the blood pressure. Same with that triggerfish lens.
Okay. I'm not sure if you'll be able to answer this one, but I think for the sake of reading them fairly, let me just read it. Is there anyone updating medical aids about this new development?
Well, it certainly isn't me. That much I can tell you. That much I'm sure about. Look, quite frankly, we have an uphill battle with medical aids. They don't even pay us for doing dilated fundus examinations and for measuring contact tonometry. So I would then advise the asker of that question to canvass the South African Optometric Association to fight that battle on our behalf, so that we are recognized as diagnostic and therapeutic practitioners and not just refractionists.
Okay. There's another one which says, what are the reliable specialty lenses on athletes, rugby, cricket, and soccer players? And what is best for pediatrics, and what is the best age to wear contact lenses in children?
Okay, so first one we said was rugby players, and can you repeat
Rugby
that?
players, athletes, cricket, and soccer.
Athletes, cricket, and soccer.
Mm-hmm.
And the second part of the question was?
What is best for pediatrics?
Okay.
And also the best age to wear contact lenses for children.
Okay. So let's talk about the sport firstly. Now, like I said earlier, there's a lens for every person, and every person is different from the other one, right? So for rugby players and cricketers and soccer players, etc., you would have to work out whether a soft lens works best for that individual based on what their vision requirements are. So if they have low refractive errors or high refractive errors, you determine what your best lens selection is, whether it requires a specialty fit or it's a straightforward soft contact lens fit, right? A scleral lens will not come off the eye, even if they stand on their heads, right? But if there's a risk of impact to the face, then you want to consider whether they could incur an injury if the lens breaks in the eye, right? So far, I haven't had any patients who played this kind of contact sport playing fitted with scleral lenses. I've actually fitted canoeists mostly with scleral lenses, cratonic canoeists and water sports people. Who wear goggles over their lenses, and where their RGPs just fall off their eyes. So you may want to consider for sport the best possible soft lens correction, maybe a hybrid lens in this case, or one of those, something like a Kerasoft lens, right, which is a specialized silicone hydrogel lens, may work best. With respect to pediatrics and children, the pre-existing condition, the reason, the indications for fitting a child with contact lenses would be what would direct you to the best choice of lens. So there isn't one lens that works best for everybody. It really depends on the underlying condition. There are certain silicone hydrogel lenses that are extended wear lenses manufactured specifically for aphakia, which can be put in for an extended period of time and then would have to be inserted and removed by the parent. Older kids can, I fitted patients from around 7, 8, 9 years of age, little ones, who are amblyopic and need or have very high anisometropia. And we're trying to reduce the amblyopia, so we fit with a scleral lens. Sorry, not a scleral lens. I might fit with a soft contact lens in that case. You got to take a number of factors into consideration: how mature the child is, how mature the parent is, whether the child and the parent are going to be able to handle it, and whether that lens is going to give you the best possible vision in that particular patient visual outcome.
Okay, thank you. I see there is a comment that tries to address the issue of medical aid to say that medical aid pays 80% on scleral contact lenses. You need to send the motivation.
Okay, yes, that's very good. That's on scleral contact lenses, but I do motivate with every scleral contact lens patient, and with some I get paid and with some I don't get paid. It really is who's sitting at the button and pushing yes.
Okay, no problem. Thank you so much for your time, colleagues, and for your attendance. We also thank you so much for your active participation. A reminder to stay up until just end of the session. Just give us 5 more minutes to do some announcements. To say, firstly, thank you also so much to Yurisa for taking time out to come and share with us this wonderful knowledge and on contact lenses and scleral contact lenses and therapeutics contact lenses. For those of you who do not know, Yurisa is quite busy. I know that she's volunteering somewhere, and she further volunteered her time this morning to come and share with us this presentation. We really note that with appreciation.
Thank you very much. And stay safe, everybody.
Before we go, just a few announcements. Next week, I know that if I don't announce this, people will be sending me emails asking me what's happening next week. So just for your information, next week, Tuesday, we have Dr. Munyadziwa Kwinda, the acting registrar of the HPCSA, speaking to us about offenses under the HPCSA Act. And I've seen that some people are asking about HPCSA. Perhaps that would be the opportune time for you to prepare your questions to the acting registrar of the HPCSA. You will be joining us next week, Tuesday. On Wednesday, we also have another exciting webinar. Most of you have been asking about how to deal with your landlords, your disagreements. Yes. So next week, we are hoping to have a lawyer on the webinar to come and talk to us about the lease agreements and how to maneuver your lease agreements during this COVID-19 pandemic. So please do join us when we do advertise. Colleagues, as you are aware, we have not asked for any payment on this platform up to now. The idea is that we want to make sure that we use this platform to promote discussions, sharing of knowledge, and debates in the industry. But as you can imagine, there are costs to running these sessions. We pay our license fees in dollars, data costs. There's an administrator behind the scenes who captures all your OP numbers and then generates your certificates. So I'm mentioning this because I want us to acknowledge and help me to acknowledge Falcon iLabs, because they've really come to the fore for the past few weeks to assist us in covering this cost. And that is why you've seen that most of our CPD sessions, we have been saying that sponsored by Falcon iLabs, they really did come through for us to assist us with this cost. But as you can imagine, we cannot milk Falcon iLabs dry. So as we go forward, we will ask you for your assistance. The idea is still to keep it free. So we are thinking of asking small donations where the colleagues can, if you have a rand, if you have 5 rands, whatever the amount, once we come out with the details, please do donate so that we can keep the platform free. There are costs, as I indicated, and we would like to cover those costs without necessarily charging for the sharing of knowledge and the discussions that we're having on the platform. So that was just to sensitize you. And in terms of your CPD points, I see that people are asking about CPD points. For those of you who are joining us for the first time, please email your OP numbers to CPD at blueconnect.co.za. So the email address again is cpd@blueconnect.co.za. Connect is with a K, not with a C. And you will get your certificate. I did say that we are currently generating certificates, so you should receive your certificates in a day or two. Only after that, please send us an email. I see that some people are sending us emails to say we must send their certificates. Please just give us some time to run the bulk emails. Otherwise, we will not be able to handle everyone requesting. As you can imagine, this session today, there's 222 people. We will not be able to generate certificates one by one. So we are working with a system. So only when there are glitches in the system, we will send your certificates directly to you. But for now, please just give us some time to run this thing. I think, and that is it for now. I'm trying to see if there's any other question that I needed to address. I think, yes. Oh, the last one was to ask you, Yurisa, to share the slides. The colleagues are asking if I can share the slides with them. So I asked that I will seek your permission first. Yurisa? Okay, I think we've lost Yurisa, but I will contact Yurisa, and as we normally do, is once we get permission, we share the slides. We have shared the slides for the past 2 presentations. We also do share the recording for this webinars. So you will, after this, get an email to give you a link to the recording of the webinar. You are more than welcome to go and view it again. If you don't get the recording or if you don't get the link, the webinars will be shared on our YouTube channel, and the name of the YouTube channel is Blue Connect. So the webinars will be shared there in about a day or two's time. So the email address again is cpd@blueconnect.co.za. Thank you so much, and the webinar will now be closed.